Good morning. This is Dr. Rutledge, and I'm doing a preliminary presentation for an upcoming IBC, the International Bariatric Club meeting coming up in 2 weeks in September. So I hope you'll come back and see the entire presentation. We're going to be talking about gastroesophageal reflux disease after bariatric surgery. And so this is a brief introduction to that topic. And so right now I'm going to turn to the slides and we'll watch the rest of the presentation. Okay, and I'm going to turn off my picture so you can see all of the slides. Okay, so we're going to talk about gastroesophageal reflux disease, the causes and the treatment and prevention. And we're going to talk about both surgical interventions and lifestyle. And we're going to talk about both prevention and treatment. So that's the overview. And we're going to have, as I say, a full complement of experts talking about this important topic, somewhat related to the mini gastric bypass. That'll be my main interest, and I hope I won't derail discussions about other operations, but let's go forward. Okay, the mini gastric bypass with understanding, we say, has power and safety. And so, of course, anybody who would like to contact me, and I'm pleased to say that surgeons and patients from around the world have talked to me, and you're welcome to contact me anytime if I can help with a patient or with any surgical questions as well. So reflux, why does it happen? How to prevent it at the time of surgery and how to resolve it postoperatively. I hope that that's some of the main topics that we'll get to address today with these international experts. And that's our excitement today. I'm gonna take a personal moment and say thank you to Dr. Kular and Dr. Magenda. It turns out that they had to suffer with me as a guest for their 1 year in 2020 because of the pandemic, and they put up with me for an entire year. I believe that they might still be recovering, but I want to express my thanks. They protected me in the midst of a pandemic, although they said because I was old, I couldn't go in the operating room. And I said, I'm not old. And they said, well, either way. So thanks to Dr. Kular and Dr. Magenda and their kind hospitality for putting up with me for a full year. And I'm also thanking my new partner, Dr. Halil Ilan in Tijuana. And thank you, Dr. Ilan, for welcoming me into a consulting role in your practice. So we have a lot of topics that I talk about. Today, we're going to talk about reflux, but there are other topics, and you're invited, of course, to contact me anytime if you want a further discussion on this. I'd like to honor Dr. Harris Kwaja and the IBC group in total. And all of us, I think, are committed to the well-being of our patients, their families, and our country's health. And again, I would offer that my services are available to help and advise anyone who has any difficulties or interest in the mini gastric bypass. I point out again, a lot of people kind of get confused about the MGB. It's nothing more than routine general surgery. The actual procedure, as those surgeons who are listening know, is it's an anticolic Billroth 2 gastrojejunostomy with the modification of the stomach into a colus gastroplasty. And in 1997, I thought that was a mouthful, so I came up with a minimally invasive gastric bypass because I was one of the first people doing laparoscopic gastric bypass those 20 some years ago. I guess now it's going to be 24 years ago on the date of this presentation. So here's our hypothesis of the presentation that we're going to talk about today. If you're seeing a lot of reflux in your surgical procedures, I'm going to suggest maybe it's you or maybe it's the patient, but maybe it's you. And what we see as mini gastric bypass surgeons around the world is a lot of excitement because it's growing so rapidly. But we also believe, I think in general, that there can be tragic or deadly consequences when the MGB is done wrong. And some of the topics that we bring up today may relate to that. So What are our goals today for the presentation? For our experts today, it is to tell you something you don't know, tell you something new, clear up something confusing, and maybe tell you something you think you know, but it's wrong. Again, this is the MGB, and we'll talk about the MGB a bit today, and also the Roux-en-Y and reflux. So what about reflux? Well, first of all, it's not just the MGB. A lot of people around the world have gastroesophageal reflux disease. It's just rampant. It's a huge cost, 4.6 million office visits in the United States, 4 million most common discharge diagnosis from hospitals in 2009 inpatient sample. In the last 3 decades, the side effect that most feared of reflux, which is esophageal cancer, has increased from 4 per 100,000 to 23 per 100,000. That's an increase of 600%. And that's not just MGB. In some series, particularly the United States, 1 out of every 5 people says that they have reflux. There's a new study saying 25%, and it's increasing rapidly. And that's not the MGB. The MGB is increasing rapidly, but we are not doing MGBs on 1/4 of the US population. So there's something going on here that's not just the MGB. So we have some hypotheses that we'll see and probably discuss later today, is that GERD after bariatric surgery can be related to the surgeon, that is the surgical technique and the performance of it, or the actual post-op patient diet and lifestyle. So it's either the surgery done well or poorly, or the post-op patient's diet and lifestyle. And we're going to give a little introduction to that as a preface to our presenters today. Maybe the biggest thing, most obvious thing that's clear from all of the studies is that high dietary fat intake increases reflux. That is, high fat. And if you have a high fat diet, generally you have to have a low fiber diet. Fiber is critically important. So high fat, low fiber may be the simplest way to imagine GERD, although we'll go into it in a little more detail. There's more to it than that. But so one of the first things we do in evaluating post-op GERD is we discuss with the patient exactly what they're eating and what they're doing. Maybe one of the biggest things that are important when I evaluate a patient, certainly we need to be concerned about the type of surgery and the particular version of the surgery. A lot of surgeons who perform what they call MGBs are done quite differently than the technique that I invented. So in addition to surgical, we find that there's a lot of research telling us that there are lifestyle and dietary choices that make a huge difference in the risk of developing or presenting with GERD. And here I'll just mention OR is the odds ratio, and I'll give you a little background on that. But so what they did is in this particular study, which I think is so valuable, is they looked at patients who did or did not have gastroesophageal reflux, and they did a variety of survey study. And so, for example, in the very first one in the top left here, midnight snacking, those people who admitted to midnight snacking on the survey had almost 600% increased risk of complaining of gastroesophageal reflux. In other words, don't snack at night. I mean, there's some basics here that are really obvious. Another one that's really interesting to me, because I see it in many of the patients I consult with, is don't skip breakfast. Your increased risk is 300% higher, 3 times higher if you skip breakfast. There are a lot of people who are involved in what's called intermittent fasting, and they think they're clever by skipping breakfast. Well, the research is clear. When you skip breakfast, you're more likely to eat more at dinner. And eating more at dinner, as we're going to see in a minute, says you're more likely to have GERD. Another thing is that people eat quickly. Nowadays, they have the TV on, they're looking at their phone, they're talking, they're trying to discipline their kids. And again, look at this, almost 5 times higher if you eat quickly. So one of our guidelines is put down your spoon between bites. You know, Eating very hot foods almost doubles the risk. Eating beyond fullness. Hello, again, if you're eating or watching TV, you don't get the signal that the stomach is full. There is a signal to send back to the brain and slows down or stops your eating. But again, when you ignore that signal, again, 300%, 3 times higher, that you're going to complain or suffer from GERD. Another study shows, another question shows that almost 20% higher risk if you eat meat, fish, or eggs. And another study, another question is high fat, and that's almost 8 times higher. I mean, there's the most powerful predictor of whether you're going to have reflux. And not surprisingly, meat, fish, and eggs are all relatively high fat. So the two things are telling you pretty much the same thing. High fat is likely to result in GE reflux. Another obvious thing, almost 8 times higher, is if you go to bed less than 3 hours after you just ate. And so many people skip breakfast, eat a big dinner, and then snack at 8 o'clock and go to bed at 10. That's a setup for reflux. Smoking increases it, alcohol consumption, and just being sad, probably related to these other things up here, can increase it. Now, there's some obvious things that decrease it. In other words, you're only going to have a complaint of gastroesophageal reflux disease in this series 1/3 of the time if you eat, quote, a vegetarian diet. And they didn't go into detail. They just asked, do you eat or avoid meat, fish, dairy, and eggs. And also proper exercise helps as well. So we know things that cause it, actively, positively cause it. And we also can see that vegetarian diets, which basically means a high fiber diet in this study, is likely to decrease that risk. So today's presentations, we're going to look at surgical and lifestyle topics and prevention versus treatment. And I'm honored and pleased to introduce the other presenters here today. Thanks very much. And that's a brief introduction of what we'll be showing in the next 2 weeks. Please join us.